Mennään ohjelmassa eteenpäin. Next, I would like to welcome Bettina Toth from Innsbruck University. She is a specialist in gynecology and fertility specifically, and has done a lot of research on recurrent miscarriage.
Yeah, thank you so much for the invitation. It's always a pleasure to meet Eero in Heidelberg, Innsbruck, or in Helsinki. Although we have only 30 minutes and it will take at least one day to talk about miscarriages, I will try to give my best to give you a short overview. And of course, it's a statement in the title that miscarriages can be treated, and I hope that I can convince you at the end of my talk. When we think about miscarriages, of course, there are international guidelines. There's a German-based guideline for Austria, Switzerland, and Germany I'm taking care of, and there's also the ESHRE guideline. And why I stress this? Because there are different kind of definitions when it comes to recurrent miscarriages. So some definitions or some societies talk about recurrent miscarriages after 3 consecutive losses and others after 2 losses. And depending on the definition you apply, you have a different kind of incidence, and it's 2 to 5% of couples who are or might be affected. We also separate early miscarriages from late. Early means in the first 3 months of pregnancy, and about 85% of miscarriages take place during that time. And we separate primary losses, so women without a live birth before, from secondary after 1 live birth. When we talk about possible risk factors which we can treat, we have, of course, the mother-to-be, and we have the maternal age as a risk factor, genetic and uterine factors, endocrine disorders, hemostatic changes we're going to look today, and immunological aspects. When it comes to the embryo, we have, of course, heard before, we can think about genetic disorders and the morphology. And I think we also have to keep in mind the father-to-be and also think about possible genetic disorders, male factors, and sperm quality. These are our own data. So when we go through a standardized diagnostic procedure and keep in mind all the possible risk factors which are mentioned in the guideline, we can identify about 50% of different of women with risk factors, and it's mainly, like you see, endocrine factors and thrombophilia, followed by immunological factors and infections, genetic disorders, and anatomical malformations. And in around 50%, we may not identify a risk factor. But I think in the future or in the last 5 years, we could identify more immunological risk factors so that this subgroup of women is decreasing, fortunately. And of course, we have to keep in mind, like we heard before, maternal age is also a major risk factor. And I want to start with this. So here you can see on the right-hand side the female age, so below 30 years, and here above 40 years. And here you can see the losses which happened, so 1 or more than 3, and the chance that another loss will happen. And you see this is quite low in women below 30 years and much higher if you are older than 40 years, and even worse when it comes to women with more than 3 miscarriages. So this is 40% in women below 30 years and up to 60% in women with 40 years and older. And I think this is really a major factor we have to keep in mind. Like we heard before, when we think about genetic factors, we have to go through the personal history, so whether or not there are known chromosomal disorders or stillbirths related to genetic disorders, but also have to keep in mind the family history of the person with chromosomal disorders and mutations. And I thought, although this might be a little bit boring, but I also wanted to show you a study which I really like, because they examined more than 90,000 couples with recurrent miscarriages. This was a study from Korea colleagues. And you see that mainly they did not find any chromosomal aberrations. So only 844 couples had a chromosomal aberrations. And I think this is good news to all of us. And what they also could find is that chromosomal aberrations led to miscarriages in young age. And like I mentioned, that the incidence of chromosomal aberrations is below 5%. And what kind of aberrations did they find? Or when they had a look about different couples, they could see that childless couples are more likely to have chromosomal aberrations as compared to parents. So here you can see the couples with chromosomal aberrations, and it's more common in couples without children. And here you can see in more detail the genetic disorders they found, like translocations. So here you can see pairs of chromosome in green and in blue. And translocation means that the blue part of the chromosome is now on the green chromosome and the other way around. And translocation is that a larger part of the chromosome of the green one is on the blue side and the other way around. And here just the order of the chromosomes is changed in case of inversions. And depending on what kind of chromosomal aberrations was present, it was more common on the female or on the male side. So this was the maternal side and in part also the paternal side. There are guidelines only recommending to look on chromosomal changes in the embryo because they argue that chromosomal changes are that seldom that on a financial aspect it's not worth checking the parents. The German-based guideline is recommending to look on chromosomal changes within the couple. Those guidelines will recommend chromosomal testing only in the embryo, state that if you could find changes in the embryo, then at the next step you can have a look whether or not they are present in the couple. I think it's also an argument. And as I mentioned before, you also have to have a look on the paternal side and also, of course, on the personal history, known chromosomal disorders, as well as the family history. We really try to get through different kinds of risk factors. The next risk factor we are going to have a look at is anatomical malformations. So we know that the uterus can have different kind of shapes, and most common are septate uterus. It's below on the left side. So you see a septate and it separates the cavum of the uterus. Of course, I show you some more pictures. So this is an ultrasound picture, and you see that dark gray part normally is not there, and it gives like a heart shape of the uterus. And although this looks nice, it's not good that it is there. So the dark gray part normally is not there, and then it's more like a round shape. And here you see pictures of a hysteroscopy. On the left side, you see the normal shape, and here you can see the entrance to the left tube and here to the right tube. And so you can imagine that there is enough space for pregnancy. And on the right side, you see a septate uterus. So this is the septum. And here's the entrance to the left tube and here to the right tube. And this can be easily done by an office hysteroscopy, which means that you take a camera and go inside the uterus, and you can even do this without anesthesia. So it can be done either by 3D ultrasound or hysteroscopy. We normally do it not by office hysteroscopy, but in our surgical department, because when you find something, then you can already treat the patient and you won't need a second procedure. The next risk factor we want to have a look about is hormones, so endocrine dysfunctions. And this is mainly about the thyroid, as well as hyperprolactinemia, PCOS syndrome, diabetes, as well as insufficiency of the corpus luteum. And we want to have a closer look on the thyroid, on the PCOS, as well as diabetes. When it comes to the thyroid, it's very important that the patient has a normal iodine intake, that you're going to have a look at the TSH level, even preconceptionally, and this should be below 2.5. And we are even thinking about selenium intake in cases of autoantibodies. So this can be easily done preconceptionally if a patient wants to get pregnant. What about PCOS patients? I think it's very important to state that not every PCOS patient is at risk for miscarriages. It's only patients with insulin resistance and also overweight PCOS patients. So if you are dealing with PCOS patients before pregnancy, it's important that they lose weight and that you treat the insulin resistance. And the same is true for diabetes patients. Not every patient with diabetes is at risk for miscarriages, but you have to have a closer look on the HbA1c levels, as well as overweight or not, and that's also very important. And the patient should definitely avoid crash diets. The next important risk factor, or not that important, but the next risk factor is hemostatic changes. And when I started to focus on miscarriages about 20 years ago, I thought this is the solution, because when you have a closer look at the miscarriages itself, you might find some coagulation parts in the placenta. So everyone at that time thought the coagulation is part of the problem and can be easily solved, for example, with low molecular weight heparin. And at that time, many studies were ongoing with low molecular weight heparin nearly for every patient after one miscarriages. And unfortunately, or whatever you're gonna state this did not show really an increase of the live birth rates. So that's why we question now hemostatic changes as a real risk factor. But nevertheless, I want to go with you through some details. I think it's very important to have a really close look on the personal history, whether there are known thrombotic events like thrombosis, embolism, or stroke, and whether you can identify risk factors. So was the thrombosis during surgery, trauma, immobilization? Is there a known hereditary or acquired thrombophilia? And also to have a closer look on the family history. Also whether there have been known thrombotic events, like I mentioned before, or known hereditary thrombophilia. Because of like mentioned in the name, acquired thrombophilia, you acquire during lifetime. And again, I want to show you a study we made with our colleagues in Heidelberg. And we included patients from Heidelberg and from Innsbruck. And you can see more than 800 patients with recurrent miscarriages, so 3 or more losses were included. And we looked on acquired thrombophilia, and inherited. And here, I hope that you can see the p-values, and they are all not bold. The only bold one is the factor VIII levels, and they were even higher in the control group. So although including a huge amount of patients, we did not find significant differences. And when we have a closer look on the guidelines, the diagnostic for inherited thrombophilia is only recommended if you have a personal or family history, but it's recommended to have a closer look on acquired thrombophilia, mainly on the antiphospholipid syndrome. And in case you're going to find this, an antiphospholipid syndrome, you go for low molecular weight heparin and aspirin during pregnancy, and, which is also important, even the 6 weeks after the delivery, because this is like important time with a high risk for thrombosis. Another risk factor we're going to have a look about is infections, mainly chronic endometritis. And the symptoms are very rare, like uterine bleeding. Some patients have pain or pain during sexual intercourse or discharge of the vagina. And when you do a hysteroscopy, you might find edema, hyperemia, or some micropolyps. And it's not easy to detect because, as you see on the left side with HE staining, it's difficult to identify the plasma cells, which are an indicator for chronic endometritis. But we can see a positive bacterial culture with mainly Escherichia coli and Enterococcus. And now the gold standard will be a staining with CD138, because then you can easily spot, and I think this is also possible for our eyes, the CD138 positive plasma cells as an indicator for chronic endometritis. And in case there is a chronic endometritis, and this is maybe about 5 to 7% of patients with recurrent miscarriages, so it's not that often. We have different kind of antibiotics we might give to the patient. And there are several studies showing a significant higher live birth rate after treatment with antibiotics. Of course, there are a myriad of possible immunological disorders we might have a look at, not in the last 10 minutes, but I want to try to give you a short overview. When we think about pregnancy, we have to keep in mind that the paternal side is completely unknown to the woman. So if she would receive an organ from her partner, she would reject this organ, of course. But she will not reject the embryo due to the feto-maternal crosstalk and a specific immunological surrounding. And this is very important, and that this is gonna functioning. There are several kind of immunological factors which are on the side. And one of the main immune cells are NK cells, and they are called natural killer cells, not because they kill the baby. They are normally there for killing infections, so bacteria and virus, or tumor cells. And when there are different kind of NK cells when it comes to the blood or the uterus. So you can see like these small things on the cell surface, and they differ and they indicate different kind of immunological pathways. So NK cells definitely have to be regarded separately, whether they come from the blood or whether they stay already in the uterus. And again, there's a study from our group, and we try to separate patients with low, normal, and high levels of uterine NK cells. And to show you, I wanted to bring some other slides, and here you can see the endometrium, you can see the stroma cells, and you can nicely see those black spots, and these are uterine NK cells, and this is a normal level, and this is a woman with highly increased uterine NK cells. What do we offer, or what kind of experience do we have with immune modulatory treatment? In case of high uterine NK cells, there are studies showing effects with lipid infusions, as well as studies showing effects with corticosteroids, and we have experience with both treatment options. Another marker which is quite important on the fetal-maternal side are regulatory T cells, and as the name indicates, they regulate not only the NK cells, but also other cells, like for example, other T cells or dendritic cells. So they are essential for the development of the fetal-maternal tolerance. And there are studies showing that in case you have too low levels of regulatory T cells, you might end up with a miscarriage. And there are also studies showing that in case of low levels of regulatory T cells, the patient might benefit of ACG, so the pregnancy hormone, which is given before the embryo transfer, for example, or in the second half of the menstrual cycle. And the last possible marker I want to talk about is B-cell lymphoma 6. It's a marker for cell cycle control, apoptosis, as well as inflammation. And there are studies showing that elevated expression is related to inflammation, to endometriosis, as well as implantation failure. And again, I want to show you some slides. So this is a normal expression on the left side, and here you can see an increased expression, and I think it's easily to see. And also here we have some studies showing a benefit in case of high expression of BCL6, and you can either do a surgical treatment or medical treatment, in this case with GnRH, and you're gonna decrease the menstrual cycle or pause the menstrual cycle for 2 months. And then in this study, they showed a higher live birth rate. But of course, when we have a closer look under endometrium, there are also cases where we can find polyps or even carcinoma. So it's very important, if you check the endometrium, not only to have a look on the immune cells, but also on other pathologies. So, as I said, we only have half an hour. I hope that I was able to show you that recurrent miscarriage can be treated. I think it's very important to have a standardized diagnostic procedure according to the guidelines and according to the experience and studies we have, and to offer treatment, not each treatment to each patient, but try to have a specific treatment for the risk factor you identified. And I want to thank you for your attention. That's my team in Innsbruck.